Good afternoon and welcome to another edition of SIF Virtual. I'm David Reisig and I'm pleased to be bringing you another interactive case review session with our panel of experts, and a panel of experts it is. From North Carolina, we have Dr. Mike Rinaldi. From Columbus, Ohio, we have both Dr. Carlos Sanchez and Dr. Steve Yakubov. From Indianapolis, Indiana, Dr. Jim Hermiller. And finally, my partner, Dr. Robert Burke, joining me from Scottsdale. Guys, it's really great to have you. These have been some great sessions that we've been doing. Today, Carlos Sanchez from Riverside Methodist is going to be our case presenter. Carlos, why don't you share your screen and take it away?
All right. Thank you very much, Dave. It is a pleasure presenting a couple of outstanding cases. Also, thank you, the panel, for being present. I'm going to start presenting me and my partner, Dr. Yakubov, presenting two very good cases related to TAVR. One is with Evolut, the other one was Sapien. Without further ado, I'm going to start the case. This is Dr. Yakubov and my disclosures. First case, this is an 83-year-old male patient. He had a history of severe COPD, pretty bad lungs with an FEV1 less than 0.8 liters, an ascending aneurysm, and coronary artery disease, who was admitted to the hospital with CHF. He had been admitted multiple times in the past. His STS predicted risk of mortality was 7% just for aortic valve replacement. Remember, he has an ascending aneurysm. He was evaluated by our heart team. You can see the echo parameters at the bottom of the screen, consistent with severe aortic stenosis. And I'm going to show the CT angiogram first, and then discuss the opinion of a panel. So the annulus was very calcified with a perimeter of 96 millimeter and an area of 675 square millimeters. That's to the left. To the right, you can see the LVOT 4 millimeters below the annulus, also very similar with a perimeter of 95 and an area of 686. The SOVs were very large and very calcified. You can see that it is a bicuspid valve anatomy. And to the right, you can see the ascending aorta, which is almost 5 centimeters in diameter.
So Carlos, when you start to see these left ventricular outflow tracts that are that large with this much calcium and a bicuspid valve, what kind of problems do you see with the measurement of the LVOT? What does it tell you should do? High implant, low implant, different types of valves? What do you think?
Well, first of all, once we start seeing a bicuspid valve, the annula, the true annulus, is going to be large. And for the most part, if it's very calcified, the true opening is going to be about 8 to 12 millimeters above. And that's what we call the supraannular opening of the aortic valve. And if there's a huge discrepancy, you have to start selecting what valve size you're going to go. And not just that, but also should you do balloon expandable versus self-expanding valve. And then you start seeing how much calcium there is. Should you predilate this cases? You should always ask those questions before you start the case, obviously, as a pre-procedure planning. But I'm going to show you, there's a little more to this case that I want to show you. You can see the coronaries are high, but there is severe aortic annular calcification. Now, to make things more interesting, I show you the ascending aorta that was almost 5 centimeters, but the aorta was also very horizontal, almost at 70 degrees. And if you look at the right, the vascular access looks very tortuous and to some extent also calcified, but good enough to get any type of valve. So I'm going to pause here and bring the panel for discussion.
Bob Burke, you're used to vetting our cases. give some of your initial impressions of what you have seen so far, and strategies, valves, CEP. How do you look at this case?
So just to begin with, thank you, David. This is a very, very challenging case from an anatomic standpoint. No matter what platform you're going to use, how you're going to go about doing it, there's a ton of calcium. You're dealing with a bicuspid valve. You've got aortopathy. You've got an unwound aorta that is very horizontal, which is going to make getting anything to lay over very complicated. This is not going to be a chip shot. So when you see that much calcium, you worry about leak. You worry about having a platform that's going to be able to mitigate against that. And you do worry a lot about, even potential rupture. Although the nice thing about this is that there's not a lot of calcium going down into the ventricle itself. So it doesn't have that super high risk of annular rupture, but you'd still have to worry about that with just putting a balloon up inside there. Peripheral access is not really straightforward. I mean, you've got a curlicue, sort of a corkscrew look going up on the femoral, which is going to be, or the iliac actually, that's going to be a real challenge to navigate. So, this is one where you're going to be looking at everything. And the coronary heights, even though they're high, to your point, Carlos, once you actually land your valve, you're going to be even higher than what you would typically measure as far as your actual annular height. So you have to worry about losing coronary height in the process when you're going to implant with this bicuspid valve.
Herms, is there a valve, as you look at this, is there a valve or maybe a couple of valves that you would definitely use or would definitely not use when you look at the overall anatomy?
Yeah. So I think out of the three that we have, this is a case, if it was a smaller valve that I'd consider Lotus, I think it's going to be too big for Lotus. I mean, this is a big annulus. Yeah. So I'm sort of down between balloon expandable and self-expanding. And I think, you could argue both ways on this. You could argue that your risk of having a rupture is going to be less with self-expanding. On the other hand, this very horizontal geometry is going to be challenging for Evolut potentially. So I think it's a coin toss, and people could argue one way or the other for it. I think for me, it'd be very reasonable. Use a Lunderquist wire, straighten everything out, put in an Evolut, and you'll have the ability to resheath and readjust as you go along with that. And I would absolutely pre-dilate as far as sizing. The ACC kind of low risk Evolut registry, they size based on the true annulus, and I would base it on that. And they had very good results with Evolut.
Mike Rinaldi, some pearls and some wisdom, if you will, on navigating the peripheral vasculature.
Yeah, so looking at that anatomy, it's both iliac arteries are complicated. It looked to me like there was more tortuosity on the right than on the left, but that last bend right at the junction of the aorta and the proximal iliac on the left was a pretty difficult turn. So the key thing is to be gentle and start with, if a J-wire won't go easily, I would use a glide wire in exchange for something stiff. Once you have your rail, then you can you can advance your sheath carefully up. Once you have a sheath that's straightened everything out, the iliacs become less of a major issue. It didn't look like they were heavily calcified or small. It's just they're tortuous. So as long as you can get things to straighten out with a stiff wire and the sheath, hopefully things will go smoother after that.
Steve Yakubov, how do you make the decision of cerebroembolic protection? I mean, I can look at this and intellectually say, wow, a lot of calcium. I think I need to use CEP, but I don't think the algorithm is quite that simple.
I agree with you, Dave. And I've spent a lot of time giving the counter argument that embolic protection really isn't necessary because the studies have never really shown that there's a big difference in stroke, or at least a statistically significant difference. However, over the past year, We've evolved our strategy from using embolic protection on only the high-risk cases, like heavily calcified annuli, heavily calcified valves, bicuspid valves, bioprosthetic valves. Now we're to a strategy where we use embolic protection on everybody. And the only
Every case?
Yeah, in every case. The only cases we don't use it on are those where the anatomy is not conducive to putting embolic protection. And, you know, many people have seen a real decrease in stroke in their program. We've had the same improvement in stroke, and we at least attribute part of that, even though I can't give you clear evidence. I do believe that this embolic protection device does decrease the risk of stroke in our practice.
Jim Hermiller, reconcile, if you will, three data sets. One is the randomized trial versus the single center trials, which were not randomized, more observational or registry trials, and then those with your own experience with CEP.
Yeah. So you know, this has been very difficult to prove in terms of clinical CVAs, right? The event rate's low. You need a very big N. And as the randomized data was really not powered to show a clinical difference. So I'm not surprised, you know, the fact we really didn't see a significant difference on MRI. Again, I think it was an issue with power. You know, for our place, we had very low risk beforehand. We were low risk using it. We do use it on just sort of high risk patients at this point, just because of finances, not anything else. You know, we need a adequately powered trial, and it's coming.
Right. Mike Rinaldi, how do you, when you're standing in the hybrid lab or at the cath lab table, how do you define high risk?
You mean in terms of use of cerebral embolic protection?
Yes.
Yeah. So I think this is a wonderful panel because there's definitely a gradation in use. So we adopted a full utilization of cerebral embolic protection as the default as soon as it was approved by the FDA, and we've used it in probably about 80% of cases. And we just exclude it in patients where we don't have good radial access or where the subclavian is too tortuous. We believe in it. Our own registry data showed a significant decrease compared to historical controls, understanding that's not a randomized trial. And while the randomized trial didn't show a statistically significant difference, it showed a numerical advantage, which was, I think, again, an underpowered issue. While we will have a large randomized trial coming, it's underway. You know, the absence of data doesn't mean the absence of benefit. And while stroke rates are relatively low at 1% to 2%, that's 1,000-fold higher than we see in the coronary lab. So to me, a uncommon but consequential event, which is difficult to study. We have a device that to me makes sense. I think the really only thing that holds people back, it doesn't cost more time. We can get our 5 cases done in one lab using embolic protection in a majority of cases. The key thing is cost, and it really just depends on how tolerant your administration is, how efficient your program is to begin with, and how much money you're making or losing in the program. But I do believe in a randomized trial. I think that just because I believe it and some people don't believe it, it's a perfect clinical equipoise, and I'm looking forward to that trial. My program believes so much in it that they wouldn't let us participate in the clinical trial, which really made me sad. But I very much support that randomized trial. So for us, we use it as default.
Carlos and Steve, you guys are at Riverside Hospital. I understand this case was done a year or so ago. If this case were being done today, what would be the strategy of bringing a patient into the hospital? Obviously, we're doing this virtually in the COVID-19 pandemic era. If you were bringing this patient in today, what would the pre-procedure testing look like?
Well, I'll answer that, Dave. Right now, our testing is required for patients who are elective procedures who have a risk of aerosolization. So if you planned on doing this with general anesthesia, intubation, or using a TE probe, we would test the patient ahead of time and make sure that they're COVID-19 negative before they came to the lab. If they are conscious sedation, which is what we do almost every one of our cases, with light conscious sedation, we don't give moderate or heavy conscious sedation to anyone, which is different than even a cardioversion would be. Those patients right now are not required to have COVID-19 testing. They're screened, the usual questions are asked, and temperature is taken. We limit visitors to the hospital, but we would not test this patient with COVID-19 testing before the procedure.
Are people reluctant, Jim Hermiller, to come to the hospital now in Indianapolis based on we're just getting over the, we're just getting on the other side, hopefully, of this pandemic? Is there still reluctance for patients to come into the hospital?
Yes. I mean, it's all about safety in their mind. And the way we've sort of dealt with it, we've got a heart hospital, we've got the big house, and we've really kept COVID in the big house and not the heart hospital, and that helps them sort of get through it. But they want to hear, what are you doing to prevent me from getting infected?
Right.
And I think that's going to be true for procedures as well as seeing our patients back in the office. Right, they're not going to come back till they feel comfortable.
This is a great.
So we actually. So the way I see it is we've done a really good job of convincing patients of the seriousness of the matter. And now that we've sort of lifted restrictions, we're going to have to do some dialing that back. The other thing that's actually been a barrier is like you said, while all of us are going to start or have started going back to elective procedures, most hospitals have not let visitors in, and my hospital hasn't let visitors in yet either, and they haven't said when they're going to. And that's a major issue for a lot of patients. They don't want to have their procedure unless their family can come into the hospital. So that, 2 years from now, maybe we won't remember this, but right now it's a thing.
I agree with that. I think that's probably one of the biggest obstacles to patients consenting to have their procedure now. Yes, the risk of, or the perceived risk of contracting COVID-19 is one issue, but when can my husband, my wife, my children come and visit? That's been one of our biggest obstacles. Well,
yeah,
Carlos,
you know what I tell them, Dave? I tell the TAVRs, you'll get to see them tomorrow when you're going home after your TAVR. Won't be that much.
Well said.
Well done.
Hey, Michael.
So Carlos, tell us what you did.
All right. So I guess I have one more question for the panel. Here you go. I heard your opinions. I think those are excellent comments about the case. If you decide to go self-expanding evolute valve, and you have to go a 34 millimeter valve, now with the vascular tortuosity, would you put a 22 French sheath or not? Would you do it sheathless or with a sheath? Remember, it's a 34, so an Evolute Pro Plus, it's an OD 22 millimeters, so you would need a 22 millimeter sheath, which means a 26 OD sheath. Or would you go just bareback?
Okay, let's have everybody on the panel give their answer. Start with Mike Rinaldi. Mike, what would you do?
Before he does that, Dave, I just want to remind everyone that Jim just spoke about the strategy being predilatation for bicuspids, heavily calcified valves. And if you used an Evolute, there's a good chance you're post-dilating. So there's a lot of switching of sheaths before and after if you decide to go bareback. So now you can give your answers.
Boy, lead the horse to water there, Yak. That's great. All right, so Mike Rinaldi.
So you asked me, yeah. So my choice would be a Sapien 3 Ultra. I'm not feeling the love on the Evolute here. So I'd be interested to hear what others say.
Okay, Jim.
So I would say if you choose an Evolute, in this, I would just set yourself up for success. 22 French, it's not that big. These look like huge iliofemorals. I would just put a sheath in, and you've done everything you possibly can, because this is going to be really challenging with a self-expanding.
Bob Burke.
Again, we go our best to have one sheath and work through the one sheath if you've got size for it.
And since I work in the same lab as Bob Burke, I got to agree with him. So
how would you plan on closing it, David?
I'd use, I mean, I think you can use a Manta, but I don't think that I would trust a Manta necessarily, only because we haven't done a Manta with this size sheath. I think I would probably use 2 per close.
Yeah, this is 2 per close. I mean, this is not something giant that we've never used before, right? Think of the old original Sapien days.
Yeah, exactly right. All right. So I'm going to have Dr. Steve Yakubov go through the presentation of the case and description.
Yeah, so on the left screen, you can see that this is trying to navigate the vascular access. And as Mike had discussed, a catheter with a glide wire was used, exchanged for a stiff wire, and then over the stiff wire, a sheath was put in place in the right groin. And on the right screen, you could see that we've crossed the valve and we're going to do balloon valvuloplasty on this case. So in this particular case, we elected to use a big sheath because it is so much easier to do balloon valvuloplasty, make the exchanges, put the valve in, post-dilate if you have just one sheath. We elected to use an evolute valve. Here's the pre-dilatation on the right. We typically use the minimum diameter for bicuspid valves, trying to prep the way, but not trying to be too aggressive.
Were you worried about annular rupture on this?
I'm worried about every rupture on this. There's LVOT calcification that's extensive. There's valvular calcification. There's annular calcification. And you have to assume that there's a fair amount of calcification of the commissures of raphe. And so I think that you're trying to clear a path. You're trying not to rip the valve. And we're trying to be as gentle as possible on this valve before we put in. And we chose an evolute in this case.
And what went into your decision to choose an evolute?
Well, the decision for the evolute was made mostly about all of the calcification of the annulus and the LVOT. And the concern here, to me, the biggest problem is a potential annular rupture. And you know, it's a big annulus. The balloon will have to be probably added to for an S3, a 29, to get adequate coverage, because I think it measured 680 on the perimeter, and it was or on the area, and it was 96 on the annular measurement.
Yeah,
so
this is huge.
Yeah, it is big. So we pre-dilated, and then you can go on, and then on the next image, you could see we had trouble passing the evolute, couldn't pass the catheter. So Dave, I tried every trick I could. What do you do then?
Well, I'm seeing what you did, and I think this is a spectacular technique. You've sort of given away what you did. You can see on the right image that I'm assuming you went in with an end snare and snared your the shaft, not the tip, but the shaft of your core valve. And as I think what you did is, as the one operator was advancing the device, you were retracting or pulling back on your end snare to lift the tip off the calcified segment of the aortic complex to try and center it more. Is that what I'm seeing? Right.
So there's a couple of things that happened in here. One is that you could change wires, you can do buddy balloons, you can do a variety of different tricks. I'll tell you, none of them worked. So we tried a variety of different techniques, tried to put a wire next to it, a 12 millimeter balloon next to that. We even sized up on the pre-dilatation strategy and still could not pass the catheter. Fortunately, we had a sheath in, so we could take the valve out and we weren't stuck. Now, those who would have chosen a Sapien 3 would say, well, I could probably get across this just by changing the flexion. And that's, I think, true, but we had chosen the evolute. We wanted to make sure that we didn't waste a valve. One thing that I will tell you is a trick, and I know, David, you've talked about this in the past, is you can snare this valve in a variety of different ways. But what we do is we give up the wire in the left ventricle here. We start all over again with a diagnostic AL1 and a wire and snare that. And then we do everything through the snared catheter and wire. Just recross the valve again, keep your snare over everything that you own, and do the procedure.
And how much, maybe you could talk, for those who haven't done this, which is probably most TAVR, it looks like you did a spectacular job at this. How much pressure are you applying to that end snare as you're pulling it?
Carlos, do you want to talk about the end snare use?
Yeah, it was actually a gooseneck snare.
Yeah.
Snare, but you apply you snare the cap of the valve, and you rope. It was like a rope the valve, and you advance the JR4 guide. So the gooseneck snare is through a JR4 guide to provide as much support as possible. There was a lot of tension trying to lift this valve. And remember, one of our concerns is we're trying to lift the valve very horizontally, or a horizontal aorta in a very calcified valve. So we're pulling and we're applying a lot of pressure towards the aortic arch. So dissection became also an issue. Finally, we were able to, as a third operator was playing with the wire and helping out, we were able to lift. But there is quite amount of pressure to try to catch and secure the valve with the snare. There's a lot of tension throughout the procedure. You just have to be careful how much you pull and push to try to avoid any type of complication.
So can I ask just a mechanistic question? So just for people who've not done this before, is the snare on the same side as the valve? Is it on the opposite groin as the valve? And where's your is your pigtail? Where is everything? And when you did this,
the first time we did it actually from the left wrist. We had the right wrist occupied with the pig. We had the right groin as the delivery and access side. So we just accessed the left wrist and utilize the left wrist, and like Carlos said, a 6 French guiding catheter as the other conduit.
It's so much easier to do the snare from the leg and just switch out the pig to the wrist. So you may have to give up your embolic protection and use that as the pigtail and use the other groin site to do the snare, which is what we did.
For this case, we gave away the embolic protection device, which was a concern as well. As you can see, the degree of calcification and how many times we're balloon dilating this valve, that was a concern, but we had no other option but to give it away and use a radial artery to snare the valve and keep the pigtail still to guide ourselves, to map out where we were in relation to the aortic valve.
You can see typically we've adopted the REO cusp overlap technique for deploying core valve, but these horizontal aortas are really difficult to do in anything but an LEO view. The angles become so profound, especially this case. It was exceptionally profound that we stayed in the LEO for deployment.
Mm-hmm.
You can go to the
next slide, Steve.
So here on the left, you can see positioning of the valve, and on the right, as the valve is being deployed, we're trying to land this as close as we can to the non-coronary cusp. The problem with the horizontal aortas is you have to really pay attention to where it's going to land on the left cusp, and so it would be so much more appreciative if we could pull this valve catheter a little bit more into the middle, pull the shaft of the catheter a little bit more into the middle to have an ideal landing on the non, and then the correct angulation onto the left.
Jim Hermiller, is as you get down into this part of the procedure, there's a lot of complexities to aligning the valve perfectly. Is this one of the arguments against balloon expandable that to use your words, you get a mulligan?
No, I mean, I think, I actually don't think so. I think, in this case, an ultra, you could put it in position and get it where you wanted and inflate it. And I think I have very high likelihood that you're going to have the position that you want. So I think this was a dealer's choice on this one to me. And as I said before, it was going to come down to horizontal aorta versus I'm worried about rupturing something.
And it also becomes, the concern of paravalvular leak versus annular rupture. There's a bit of a trade-off there, which one you're willing to have a higher risk of during the case.
So I want you to pay attention to the snare now. We're talking about the snare to the left, still attached in the same position, but to the right, we have to move it because as you start unsheathing the valve, you also need to start walking back the snare. Otherwise, you're going to capture the valve as well as you unsheath the evolute valve.
The other option is to take the snare off, loosen up the snare entirely if you believe you have the valve in the right position and pull it up on the catheter. Knowing that that might be, if you need the snare to help you pull some more to get the shaft of the catheter in the right position, it might be difficult to re-advance it. Okay, you can go to the next slide. And here's the final deployment of the valve. So we do have somewhat of a waist in there, which is typically what is seen on bicuspid valves. We didn't feel like the valve was fully expanded. We typically move the II into both the LAO and the RAO views to make sure that the valve is fully expanded. We weren't really happy with the expansion of the valve, so on the right, we post-dilated it. Typically, when we post-dilate an evolute valve, we're conscious of the mean diameter of the annular measurement. So we usually would like to size a true balloon to the mean diameter of the annulus, but we never go more than 2 millimeters more than the constrained portion of the valve. In this case, it's a 34 valve. The constrained portion is 26. We would never use more than a 28 true balloon. Now, fortunately, I don't think there is more than a 28 true balloon. That's the largest one we have in our lab.
And Steve, let me just ask you, is that a Lundy in there? What's the wire?
That was a Lunderquist wire.
Yeah.
Yeah. So, I think you can go on to the next slide.
Dave, do you use a Lunderquist whenever you use a 34 or not necessarily?
Yeah, we've been using Lunderquist a little bit more frequently since we've adopted this RAO cusp overlap technique. The Lunderquist wire actually gives you just a little bit better control. Now, again, this was not done in an RAO cusp overlap technique, but what happens with using the cusp overlap technique is that it's typically an areocaudal view. The pigtail is in the non-corner cusp, and that is really the best view to know that you're at the bottom of the non-coronary cusp. We use pigtail and non-coronary cusp for every procedure we do, whether it is a S3, an evolute, a lotus. We're always in the non-coronary cusp. We always deploy off of that. But the areocaudal really does show you the bottom of the non-coronary cusp the best. We will then roll the camera over to the left after we've deployed the valve to 80% to see where it's going to land on the left cusp and then do final release there. It's really a simple technique. The Lunderquist wire helps you control where you are on the non-coronary cusp. One other thing that we've been adopting is a little bit of a hair of a forward pressure on the wire as we're deploying, just to make sure we have that valve in exactly the right spot. Again, a goal of this cusp overlap technique is to land the valve in the membranous septum and decrease our chances of pacemaker. And our pacemaker rate has dropped tremendously with evolute just by using these simple technique changes.
Mm-hmm.
I have to say that being able to position this valve where you did in a horizontal aorta with an aneurysm, with a snare, is just a testament to the skill of the operators. That's a pretty impressive feat.
I got to agree with that.
It's always good to have Carlos with me. He tells me what to do every step of the way. Now here's the echocardiogram. This is the final echocardiogram after post-dilatation. We didn't have much paravalvular leak, but we do like to see that the valve has a normal shape, because we're concerned that if we leave that constrained portion, it might affect the longevity of the valve, maybe the ultimate functioning. I have no data to support that, but that's why we did post-dilatation. And we were very happy with almost no PVL at the end of this procedure.
Bob Burke, if this were our case and you were doing echo, interpret this for us. What are you seeing?
So this looks great. The initial basically parasternal long axis view looks like it's pretty, well, obviously very vertical looking heart here. The valve itself looks great. You see there's basically the beginning of the stent is nice and parallel. You don't see any constraint like you were saying. On the zoomed view, you also see that it's really nicely laid out, you know, maybe a touch deep on the mitral, but really nothing to write home about. We would typically go from that zoomed view into color and also do a short axis just to confirm any issues with PVL.
Bob, is there an angiographic view that could have helped me avoid a deeper implant on the anterior mitral leaflet here? Is there something that I could have done different?
Not really from an angiographic standpoint. You know, the echo versus angiography is always a little bit of a challenge. And I think the biggest advantage that we have by doing TEE is that we really do have the ability to define exactly where we are on the anterior mitral leaflet. In a case like this, you know, you've got a large heart, you've got a large anterior leaflet, you're not getting it into any trouble with functional mitral stenosis or anything along those lines. That's not going to become a problem for you.
Because we tend to ignore the right cusp when we're doing these techniques. We're in the cusp overlap technique. We know that the right cusp is overlapped on the left in the ariocaudal. We've assumed that they're in a coplanar view. When we roll over to the LAO projection, we're not really sure all the time where the right cusp is. And yeah. I didn't know if there's any echo tricks or things that you could help us with the directionality of landing.
It's really hard. You know, that's probably the toughest thing with sedation cases, is to really say exactly where you are before you're going to land, because it's a hassle with getting in there, putting the probe on the chest, and, you know, getting the II out of the way sometimes. So it becomes a little bit more difficult. Again, we're biased toward being you know, sort of a maximalist crew here, and using TEE so that we can really confirm what we think we're seeing. But this was beautiful. And you can see on the short axis on the right side here with color, you've got great imaging. Really, at most, you've got mild PVL there at 9 o'clock. There may be a trivial little dot there at 4 o'clock. But again, this is nothing to write home about. You do not see this, and you will not see this on that image on the left, because when you're cutting through the valve on that image on the left, you're sort of going a 12 to 6, because that's really the widest part of the valve itself. So you're looking from 12 o'clock to 6 o'clock. So those things that lay out at either 9 o'clock or 3 o'clock are always going to be tough unless you sweep and sort of go off axis. And then you're sort of in no man's land, and it's hard to be very specific about, well, where is the problem? So that's why that short axis view that you have on the right is so helpful.
Steve, I think this looks spectacular. I like Mike Rinaldi said, with all of the things you are navigating from the leg to the aortic valve complex, this is really spectacular. Let me ask you, Steve, if you had a 29 Lotus, might that have been a consideration, or no, that wouldn't have changed your mind?
We really like Lotus. We had a great proctor named David Ryzik who came and showed us how to use it. Carlos and I we've adopted many of the things that you've told us, all these tips and tricks, and we're very fond of the device. I think it, you know, you talked about getting a mulligan with resheathing with Evolut. Well, you have that with Lotus also. We like to land the Lotus maybe a little bit higher than normal. We love it for the bicuspid valves. We love it for valves that have excessive calcification, because you almost see no PVL ever. So this would have been a great case for a large enough Lotus. We just don't have one.
Would you have, Jim, if this were your case, would you have almost defaulted or been okay with a resheath, with a partial resheath and mechanical valvuloplasty on this one? Or would mechanical valvuloplasty in your mind with the Lotus not have made a difference on this?
I would pre-dilate it. I just, as complex and as much calcium in this case, it's just another factor in trying to set yourself up to win. And that's what I do.
Okay.
But no doubt that in very calcified annuli and high-risk patients, Lotus it's definitely a really good addition to the armamentarium of valves that we have. And a 29 would be welcome for cases like this, no doubt about it.
Good. When Boston Scientific logs on to SIF Virtual, they'll have heard you. This is like incredible. I learned so much from this case. Anything else, Mike Rinaldi? Closing comments on this case. Are there any more images, Carlos?
Not for this case.
Okay. Mike Rinaldi, closing comments.
Yeah, this was a really tough case. The outcome was amazing. Very nice troubleshooting through each of the problems. Certainly you can use either valve in this case. A very nice demonstration of how to use Evolut technology. And these are the balances between the two technologies. You know, annular rupture is not something you usually come back from. So not only did they not have annular rupture, but they didn't have PVL. That's a huge win. Great case.
Great case. All right. That was. How do you do a second case after that, my lord? All right, so let's get on to the second case.
All right. So we'll go the opposite direction with this case in terms of complexity, but very interesting case as well. This one was a 68-year-old gentleman with a history of CABG ×2, meaning he had the first bypass surgery in 2001, and 4 or 5 years later, he had the second bypass surgery. He has had multiple stents, progressive coronary disease. You looked at this guy, he looked in the low-risk category, but based on his coronary bypass surgeries, his STS was calculated at 4.9% for mortality. He had dyspnea on exertion, NYHA functional class 3, evaluated by our heart team. The patient was really, really worried about having a third time surgery. We had multiple discussions with him. Here is the echocardiogram. This had a mixed aortic valve pathology. As you can see, it's mildly calcified. There was moderate aortic stenosis, but there was also moderate to severe aortic insufficiency. You can see the left ventricle, and Bob, you can give your opinion about what you think, but it looks to me dilated on the left and on the right.
Yeah, so you definitely have dilated LV. The aortic valve, it looks like you're probably going to have a fair amount of calcium there on the right cusp. I mean, we'll get more information when we take a look at the CT. You do have some shadowing, so at least it gives you a little bit of hope that you might have something that you're going to be able to hold on to with TAVR. But again, this really looks like predominantly an AI valve, which is going to make everything a bit more challenging.
All right, so I will show you the CT. This is a CT angiogram. To the left is the aortic valve annuli, another big annulus, perimeter of 88, area of 577. You can see to the right, it's the LVOT, 4 millimeters below the annulus. It widens out a little. The perimeter is 92 and the area is 632.
Yeah, so again, you're seeing that you've got a large annulus. You do have that spike of calcium that's going down, this time into the septum. Really nothing going along the aortomitral continuity there. It's going to be a large valve. Nothing you're going to do about that one. So you really want to be able to get something that's big enough that you're going to be able to lock it down inside that space and not get into trouble with embolization.
So Dave, I know this patient very, very well. In fact, I tried to talk him into surgery, half a dozen times because I'm not very happy about the amount of calcium that we see. I also get a little concerned when the LVOT is bigger than the aortic annulus, and those are trouble. His left ventricular function was poor, and he told me the first operation that he had, and he was in the hospital for 32 days, and he's not doing that again. Second operation was not very pleasant either. And he just told me, there's no way I'm having an operation over and over again. So with all of those factors, what would you do?
You had me at probably the first operation. I think this, as painful as this likely is to be, I would definitely opt for catheter-based valve therapy here and not send him for another surgery. He's had 2 surgeries. And while there's going to be some pain points in a catheter-based therapy, I think a third operation on this patient is just something I don't want to do. Herms, does that make sense to you?
Yeah. No, I think clearly a transcatheter, three strikes with another surgery for this.
Does anybody think the valve's going to float away?
So let me ask you this:
Well,
do we have a CT of the leaflets a little bit higher than the annulus? I just want to see what.
Just going to ask the same thing.
Well, that doesn't help me much.
Yeah.
Once you get into the sinus, you're too high to really see the leaflets themselves.
Yeah, you got a hockey puck?
Hockey puck, yeah, that would help.
We had one. There's very little or no calcification.
Okay, so this is what I think. You got at the annulus 577. I would be try and go 20% bigger than that, and I would add 2 to 3 cc's to a 29 and go for it.
I agree with that. I'd add a couple of cc's to a 29. And I'm not even sure that's going to do it for you. I still have concerns about this thing floating away. I did a similar case like this with Bill O'Neill up at Henry Ford, and it was during the Lotus proctoring up there. And I will tell you, we did a very aggressive tug test on this with the Lotus device to make certain that this didn't move. There's no device that I'm really feeling confident isn't going to take a ride once you release it.
Very good. So this is the sinuses of Valsalva. To the left, you can see very large sinuses. And to the right, it's kind of an oblique view just to show you that the annulus opens up, that the LVOT opens up, which is what we discussed already, problematic in trying to decide what valve, but not just that, how much, if you're going to pick a sapien valve, are you going to add a couple cc's, 4 cc's, and then where are you going to land this valve? So important questions to keep in mind.
Steve, how do you reconcile? I'm sorry about that, Carlos. Steve, how do you reconcile? I mean, there's a very clear difference oftentimes when we look at the amount of calcium we see on an echo and an absolute paucity of calcium on a CT scan. How do you balance that or make a decision? Do I have enough calcium to latch onto, or do I not have enough calcium to latch onto?
I typically trust the CT. I'd like to hear what Bob has to say with that, but I think the CT tells me more about calcium than anything else.
So CT, since I play around with those two, is dependent upon how much you gain things up or gain them down. So you can sort of manipulate that piece of it depending upon what your settings are. And so you can give yourself a false sense of security if you overgain it, like anything else, and say, oh yeah, we've got a lot of calcium. The echo, the one thing that I do like on echo is when you've got a lot of shadowing to the valve, to the chunks, you've got a fair amount of calcium inside there. So that can be pretty helpful. And also just the absolute thickness of the tissue. Sometimes you'll have a really fibrotic, nasty, immobile valve leaflet that, it's immobile, but it's really not terribly calcified. So getting that piece of information on the TE can be very, very helpful.
Yeah, I thought the echo looked a lot worse than the CT.
That was exactly my point, Herms. I thought we were going to see more calcium on the CT, but really nothing.
David, you asked me to show cases that aren't always your proudest moments. So that's what we're doing here. And this one gave me a lot of pause.
Yeah.
I want to just say, Yak, everything you do makes me proud.
I thought you were going to say
Makes me pause.
And I'm telling Chris Woolley right now, do not edit that out, Chris. I want everybody to know.
So everything I do gives you pause. I agree with that.
Proud. The other P word, proud. All right, Carlos, what'd you do?
This is a vascular access, big vessels, no problems with access side, obviously. So strategy again, TAVR versus SAVR, which we discussed already. If we're going to go TAVR, what valve? The problems that we foresee is very little calcium. It is AS, but there's also AI, which it's a predominant problem.
I would tell you this. What valve? I don't know the answer. I've had good experiences and bad experiences with each valve. We had a core valve that ended up being an unmitigated disaster, similar case to this. And I've had core valves that have done very well. We've done some S3s in this setting. Most have gone well. One didn't go so well. And we have a lot of Lotus experience, obviously. I don't know that I can clearly say what valve it is. I do know that the night before this case, I'm doing a novena to St. Jude.
Yeah, I do exactly the same thing, Dave.
Yeah, we do have experience with multiple valves on patients who have predominant aortic insufficiency. With Evolut, we tend to stay there a long, long time before we do final release, just to make sure the valve isn't going to move. With an S3, you have the one shot of doing it. Lotus, certainly you have more than one opportunity to get it right, but this is really too big for Lotus.
I think it's too big for Lotus.
It's way too big.
Yeah, so either taking a shot with, in this particular case, the cage of the Evolut does not help you stabilize the valve because the aorta is a little big. So, which happens a lot with aortic insufficiency. So we talked a lot about this and we decided to choose an S3.
We had a case like this, and Bob Burke, you can talk about your observations from that case. We thought it went great. He was doing great the next day. And then he developed a cough, and he was coughing for the better part of an hour. And I don't know which was chicken and egg, but that valve, I think from all the coughing, he coughed it right into the left ventricle. A lot of intrathoracic.
I'm guessing it was pulmonary edema.
Okay, you can go on to the next slide.
So I would say one thing about this case, though, I mean, the size is 577. It's not 640 or 650. If it was that, it would be a no-go. I mean, if that's the right size, you can get a 20% up on it. If you can't get to 20% bigger, I think don't try it. And the other thing I'd say is don't get too fancy here, huh?
Carlos,
Okay.
how much extra was put in the balloon on this procedure?
Oh.
Yes.
Yeah, we're all seeing it now.
Now, do you remember how much extra was put into the balloon when we started?
4 cc's were put on to this balloon. Because
and it knocked the pacemaker out.
There are PVCs here, no?
I think this is an issue of reliable versus unreliable pacing, because I think I'm seeing a PVC here. Is that correct?
I think the pacemaker was unreliable, and that's what knocked us out. And it was going well until final deployment. So the valve was deployed, and you can see where it lands on the right, where it looks like it's above the pigtail in the non-coronary cusp, which always worries me. That means that the valve is out. The good news is he was perfectly hemodynamically stable. So if you're perfectly hemodynamically stable, you could collect your thoughts for a minute and try to figure out what to do. What would you do?
Herms?
Don't lose the wire. Don't lose the wire. you can try with the balloon that you have in there to try and catch it and either, pull it up. The trouble is you're not going to be able to deploy this, and that's a big ascending aorta. Can you luck out and get it to go back down? Probably not. But I think the first thing is don't let this thing flip over and land someplace and it's upside down.
So is it free floating or is it partially captured on the leaflet?
Not free floating, Mike. That's a good point. And you can see that it doesn't, you could also see that it's not fully deployed. If you look at the final inflation, it doesn't look like the valve is totally deployed. And it's not free floating, and the patient's hemodynamically stable. There is AI, but it's not one of those where the aortic diastolic is matching the LV end diastolic pressure.
So you can tell when somebody asks a question like that it's happened to them too. So, yeah.
So now, I like what Herms said. The only mistake and the biggest mistake is losing the wire. If you have as long as you have the wire in and the patient is hemodynamically stable, as Jack said, you can collect your thoughts. Never, never, ever surrender the wire. We've had one like this that tumbled on us because the case was essentially done. The wire was back and it tumbled and it inverted on us. And so in that particular case, having seen Herms lecture on this 3 or 4 times before that case, I did exactly what Herms said to do in his lecture. I recrossed it, brought it over the aortic arch, implanted it, inverted, and then put a large palmaz in it. But here, the patient is hemodynamically stable and you have your wire. I think one of the tricks here is to take your balloon and see if you can possibly carefully use your pusher or your device to tease it back down a little bit, but you don't want to put too much pressure on it and push it all the way into the ventricle.
And that's exactly what we did. You can go to the next. I think using the pusher helps. We put the balloon back in there to see exactly. There's our picture on the right of what the balloon looked like. So the picture on the left is the angiogram showing that there is some aortic insufficiency, but it's not profound, and the valve doesn't look fully deployed.
Yeah.
And so we were able to use the balloon with the pusher. You can see the pusher's been advanced, and the pusher then kind of freezes how high the balloon could go back, forces it into the ventricle a little bit.
How much pressure were you putting on this, Yak?
Well, it's probably as much as I could. The pusher helps you there. The pusher helps you from floating backwards. It almost forces the balloon into the ventricle to some extent. But we did a full balloon expansion. You could see how much the valve changes at that point in time. And it didn't move back, which made us really feel like we had sealed the leaflets.
Yeah. What's interesting there is that when you look at the valve fluoroscopically, it does seem like the valve moves closer to the annulus, but it also shortens. It's like it's accordioning a little bit.
So I want to make a couple observations. To the left, we already mentioned that the valve is not deployed. So when the valve jumped out of the annuli, we stopped the deployment and the patient was hemodynamically stable to think about it. But look where the pusher is on the left. It's all the way back. And to gain support, look where the pusher is on the right. We advanced the pusher just to be right at the tip of the balloon. So once we start inflating the balloon, we would have more pushability and more help from the pusher to get the valve in position. And just a reminder, that most distal tip is where the balloon typically begins.
Now the pigtail was not purposely wrapped around like it is. I think it moved during the inflation. We're more concerned about putting the valve in the right place, but it also helps you to know exactly where you are.
Yeah.
So then we pulled the balloon back And this is what the valve looks like. I think we have complete sealing in the leaflets. We probably have some in the annulus, but it's mostly in the leaflets.
So this brings up a great question, which is, do you feel confident that it's going to stay where it is, or do you put a second valve in just to make sure that it's stable? And I don't know the answer to that. I have put a second valve in this situation, even though I had no leak and it looked like it was okay, but it was just hanging on. It was actually deployed in the leaflets, not at the annulus, but it was actually a good result, but I just didn't feel confident about it. And maybe I'm going to learn something here.
Well, there's I'll tell you, Mike, that's a great question. Now, there is a lot of time that went between the last image of that balloon being up until the point where we pulled the wire out and the pigtail, we take this final angiogram. So that we felt confident that the valve was going to stay in place. Carlos, you felt that the valve was in a good position, right?
Yeah, we debated back and forth your point, Mike, and we thought about it every time we thought about instability and potentially embolization. You know, we would took another picture, and we stayed in the lab like 30 more minutes watching this valve, but really it didn't move. It looked
we had him cough, we had him Valsalva, we had him do all kinds of things to try to see if it would dislodge. Nothing happened.
There's going to be no pacemaker in this case.
Yeah. And, you know, all the forces are driving it in diastole down to the ventricle, not the other way. So it's not like it's a deep implant. So yeah, that's great. And I think you're on the annulus on the left, in the left cusp, and leaflets all the way over there in the
Let's
non.
see what Bob thinks of the echo. Bob, where do you think we are? Go ahead to the next images.
So again, you are as high as you could possibly be.
Perfect place.
I suspect that, you know, the lack of calcium, particularly in the non-coronary cusp, may have played to your advantage, because there's a good chance that it actually would fold over when you were pushing it back down. Because if it was caught under there, it could just crumple and, again, help to assist with some of the seal when you finally deployed. But this looks beautiful. You don't see any real contact at the level of the aortomitral continuity, and that's typically non. And I really can't even differentiate where the strut is initially. We need to go and zoom in there and probably get another look at that to really define the border of the stent. But I suspect that it's relatively, well, we know that it's high. Right here on color, you got color compare, and this looks beautiful. The height, because it is high, again, you're not getting in trouble with the coronaries. This is fabulous.
Yeah, this is a super annular balloon expandable.
With no risk of permanent pacemaker requirements.
Yeah, so, you know, the pacemaker certainly hurt us on this case. We've moved to using most of our pacing on LV wires. The reason for that is, you know, we're spending all our money on embolic protection. We may save a few bucks by not using the pacer. Plus, we like pacing off the LV wire, and it avoids another access in the femoral art or in femoral vein, which potentially could cause a little bit of bleeding. So I don't know if the rest of you guys are doing the same.
Yeah, explain how that works, because it's not, you know, it's not. There's some tricks to it, and I think it's a great technique, but it has to be reliable. There are certain things about, you know, if you could also touch on when you put the valve in, even though you've got the wire stable and it had contact when you tested it, does putting the valve in change the position of the wire and maybe mess up your potential for contact? So tell us your tips and tricks about this technique.
Carlos, you want to take that?
Yeah. So we use, for the most part, a pre-shaped wire, or like Steve was saying in the previous case, sometimes a Lunderquist when we want to go cusp overlap with an evolute valve. But you're right, Mike. We advance the wire all the way to the apex. We want to make sure that you're making contact, especially the loop of the pre-shaped wire, against the whole myocardium or endocardium. And you have to scrape, if you're using a Confida wire or any other type of wire that has a hydrophilic coating, you have to scrape the back end of the wire. Then remember, you need the alligator clips that you're going to use. So one one alligator clip goes to the end of the wire, but the other one, you got to put a needle in the skin or something that will hold the alligator attached.
And ground the patient.
And ground the pacemaker and the patient. So with that said, we test the pacemaker very carefully. We make sure that we have good capture without forgetting that if you start playing the wire and you pull the wire back, you're going to lose capture. And that's very, very important with sapien valves, because if you start moving the wire and you forget about it and you lose capture, this valve is going to fly out. On the contrary, if you push the wire too hard, you're going to start creating PVCs, even if you're pacing. So you have to have the wire in a very stable position. And once you're sure that the wire is in a very stable position, it's capturing well, then you leave it there and do your procedure, either self-expanding or balloon expanding valves.
I have to tell you that I like pacing off the LV wire better than the temporary wires in the right ventricle. I think that they're more stable, not less stable. And, we don't always use the pacing on evolute valves. Many times we do, and we manipulate the wire a little bit more with evolute, but we don't manipulate it to the point of losing capture. On the evolute deployment, it's the pressure on the wire is a little bit more forward rather than backwards, and we don't usually need it for final deployment. For Edwards, the wire stays in the same spot for the whole deployment procedure. So I kind of like it. Is anybody else using it routinely?
We are not. Herms, are you using it?
No, we just.
I will remind you, Jim Hermiller, that at SIF 2013, you gave the lead-off talk on TAVR and the TAVR session on complications, and it was valve migration. And your first slide in prevention of valve migration, the very first slide that you had, the very first sentence on the very first slide is ensure that you have reliable pacing. And this is something that we think we test for. We always ask our anesthesiologist at the head of the table, test your pacemaker for reliable pacing, but then it always remains a little unpredictable. So I don't know, Bob, I think maybe we ought to adopt what they've done in Columbus, Ohio.
Yeah, this looks great.
These were some really, really tremendous cases. And I agree with you, Yak. We learn more from the more complex, even complicated cases. And I applaud you for showing this case, because I learned a tremendous amount and things that we can actually apply in our lab. So let's go around the table and each give our parting shots. We'll start with you, Herms.
Yeah, so spectacular cases. I think for the first, everything you need to know about complex bicuspid disease was shown. Difficult crossing of the valve with the prosthesis. What are some of the tricks, some specific tricks about the evolute and that horizontal aorta that people can take home? Second case, just a beautiful example of predominantly AI and all the things that you think about to hopefully get that to come out good, which, let's say too often these days doesn't. We don't have the device we want, but spectacular way that this was handled.
Carlos?
My biggest comment here is that I'm grateful to be here with a panel like all you guys. I always learn a lot from you and your experience. But one comment I'm going to make about these two cases is that these two cases do not represent evidence-based medicine at all. None of these cases would have been enrolled in any trial, I believe, in the present. So it's very important to get them out and show the community that we can treat those patients. Yes, they are very difficult, but in the expert hands, it is doable. And we just have to respect the anatomy, and pre-planning is super important with this type of cases.
Yak?
There's a couple of things. First of all, Carlos emphasize pre-planning, and there's no one that's better at that than he is. You know, if you're lucky enough to have an expert CT imager working alongside you on this, it makes the procedures so much easier. The other comment is, I've been coming to SIF for many years. The cases that we share are really important, but I could tell you that many of the tricks that were demonstrated here were talked about in lectures by you, especially snaring the valve, tricks of getting up tortuous anatomy from Mike. And then I could still hear that same ringing in my ear from Herms that don't you ever lose the wire on the sapien valve that you don't know is in the right place. So, you know, I've learned a lot of that from this course, and I appreciate being part of it.
Oh, that's so nice of you to say, yeah. Thank you. Mike Rinaldi.
Yeah, I'll
As
close it up.
always, Mike Rinaldi, final word.
So I would say that I love these case-based complications or near complication cases, and I like that we talk about them in ways where, you know, like I don't think I have a lot of experience with snaring a valve to get in position. Maybe we've done it a couple times, but I don't remember the steps. And talking through these things in a step-by-step way makes me think about it. So when this stuff happens to me, I know what to do. And if a valve deploys high, you know, what are the steps to think about? Because when you're in the thick of it, you may not remember all this stuff. But if you just heard about it recently, you can sort of settle yourself easily in more easy fashion and get it done right. So I really appreciate, I think this is the best stuff that we show at conferences. So I appreciate it.
I agree with that, Mike. I want to thank you guys. You are really an all-star panel, no question. Bob Burke and I love doing these sessions because we learn so much and we apply so much of what we learn from the four of you. So thank you very much. Carlos, I especially want to thank you. What great cases to learn from. The didactic lectures are good, but nothing like case-based lectures and these sorts of discussions. So I thank each of you for joining us here at SIF Virtual, and I look forward to our next session in several weeks. Thank you very much.
Thank you.
Thank you.
Thank you.